Hello, my name is Damien Descheus. I'm a gynecologist and medical director in Women's Health Institute here in Barcelona, and I'd like to present you this lecture, title of which is Daily Practice with HPV Positive Patients, Non-Invasive Treatment or Wait-and-See Strategies. Just as a brief introduction, we all know how important HPV infection is nowadays. We know that it's the most common viral infection when it comes to a reproductive tract, especially cervix. We probably can consider that almost every sexually active woman will at some point be infected by HPV. So that gives us an idea of how important the volume of this and the consequences of which this could be. Cervical cancer is the fourth most frequent cancer worldwide. Unluckily for all of us, we still have two big figures. These are numbers that we shouldn't be dealing with them. We know we have to improve basically in terms of vaccination. We have to improve in terms of screening programs. But this gives us an idea of how important HPV infections might be. They're not only responsible for cervical cancer, but they've been also related to other cancers, being anal region, being oropharyngeal region, being vagina and vulva. So it's a very important incidence all over the place. It was the first tumor to be recognized by the World Health Organization as attributable to just a viral infection. So that's really important because we know then who's the important guy there. HPV is the important guy. We need to do something about it. You all know the natural history of HPV infections. This inverted pyramid has a very wide base in which we would be finding all the HPV positive patients. Luckily for all of us, just maybe over 20% of them will progress to a low-grade lesion. 10 to 15% of them will go to a high-grade lesion, and up to 20% of them will go for a cervical cancer. So that's a tragedy, knowing that we have probably from maybe 10 to 15 years a gap of time in which we could be doing something about it. We shouldn't reach that end point of cervical cancer. We know that progression is possible, but we also know that regression is also possible. Spontaneous regression has a very high rate, maybe up to 80%. But we need to do something about those women who don't regress spontaneously, because those are the women that might be at risk of developing lesions and then cancer. This is probably the very important slide here, because we need to make this very, very clear. We've never been saying that vaccination is not the way to go. This has to be the key message here. We're not talking about vaccination. Vaccination is obviously the way we have to go. We know it has limitations, but we have to deal with them. But vaccination is clearly the best strategy possible. So we're not discussing that. We're only saying at some points vaccination might not be as effective as we want it, especially in some patients. At least here in Spain, the rate of 34-year-olds or older women that have been vaccinated is very low. Not something that's our fault, it's gynecologists' fault. We need to do something there, but it's still too low. We know that if these women and men, but these women are not vaccinated before they start having sexual behavior, sexual contact, we're losing an opportunity. So let's get this first message very clear. Vaccination is the way to go. We know that dealing with a message of an HPV positive result causes stress. And we know that usually stress has been considered kind of a minor problem, and it's not at all a minor problem. Not only because perceived stress by the patient is not a good news, obviously, but also because we already know now that stress can also have an impact in the immune system, and then be in a way favoring the HPV persistence, and we know that that's what we don't want. Okay, so when we used to talk about stress as something minor, we now know that it's no way a minor issue. which are the modifiable factors that can be associated to HPV persistence? One is the status of the transformation zone. If we're able to get very quickly epithelialized transformation zones, small transformation zones, we might be reducing the opportunity for this virus to get into the tissue. And thus then we should be able to reduce the chance that the virus has to really create future problems. There's huge information going on nowadays in terms of the relationship between cervical lesions, HPV positive women, HPV persistency, and vaginal microbiota. We know that a bacterial diversity in the microbiota, in the vaginal microbiota, is predictive of progression to CIN2+ lesions. So let's put it the other way, and we have to prove that. We have to demonstrate that this is correct, but it does make sense to think that it should be this way. Let's try and again gain vaginal microbiotas in which diversity is very low, basically CST type 1, 2, or 5 microbiotas. These seem to be microbiotas that are less related to high-grade lesions or persistence of HPV. We should also have the opportunity of changing the immune status of women. We've tried to demonstrate with our vaginal gel that we are able to modify the immune response at a local area, and that is by using the vaginal gel. It's been also demonstrated in the past with oral prescriptions, and I'll show you that a little bit later. In terms of healthy lifestyle, well, it doesn't make too much sense to go over this because we've already known for a very long time that smoking is not a good idea. We already know the impact that smoking might have in terms of persistence of HPV. So we should go there, clearly counseling for healthy habits. When it comes to microbiota, if we talk about dysbiosis, we know that it's a very probable cofactor of acquisition, but also of prevalence of HPV infections. If we're able to keep microbiota stable with a clear abundance of lactobacillus, especially crispatus, which has been always considered the best. But let's just stick to lactobacillus generally, okay? But if we're able to keep lactobacillus crispatus or lactobacillus as a main dominant bacteria in the vaginal microbiome, and we eliminate from the equation Gardnerella vaginalis or cousins of Gardnerella vaginalis such as Prevotella or all the others, Fusobacterium, then we will probably be generating a situation in which HPV doesn't feel too comfortable. And either we won't be, or it won't be able to really infect these women, or persistence will be less probable if we're able to change this vaginal status. So, can we do something about this? Can we improve our HPV positive patients' situations? And if yes, how? Well, that's the reason why we've been testing our products for a very long time now. We started maybe 9 to 10 years ago, and these are the results I want to show you today. What is Papilocare? Papilocare is a Coriolis-based gel, and it's using a special technology using neosomes. Neosomes might seem very similar to phytosomes, but they're not exactly the same. Neosomes have the capability of penetrating to deeper layers, and thus sending the products that we want, that we install there in that neosome. They'll go to deeper layers and will show all their activity where we want them to show it. Okay, Coriolis-based gel contains other substances such as aloe vera, such as neem. They all seem to be helping Coriolis versicolor in both re-epithelializing the cervical tissue, but also and especially changing the immune response. So, if we go back to what we were thinking previously, can we do something about epithelialization of the cervical tissue? And we can, and I'll show you later. Can we do something, and we should be doing something about the balance in terms of microbiotas that are clearly dominated by lactobacillus? We should be able to do that. And can we counteract in some way the non-inflammatory microenvironment created by the virus? And the answer is yes. And we also demonstrated that with our studies. I want to go over this just very briefly. This is what we've been doing for the last, as I said, not a decade, but 9 years probably. We still have ongoing studies. I won't go over them, but I want to show you what we've been doing, publishing, and what we're still doing in terms of HPV. Epicervix was a very simple study, 21 days, and we only wanted to prove that we were able to change the status of the microbiome by using, for just 21 days, this vaginal gel. This has been already published, and these were the results. By using the Shannon index, we showed how there was a significant change in terms of the microbiota diversity, meaning this that it went to a lower diversity, and remember that that's good news. But we also demonstrated that the population of Lactobacillus went up and the population of Gardnerella vaginalis went down. And that again is good news, because should be changing the vaginal type, the CST that we're dealing with. The first really very ambitious study was the Paloma trial. The Paloma trial was a phase 2b randomized trial in which we had 3 arms, 2 arms with treatment, different dosage, and a control group. Very briefly, these are some of the results that we've already published, but we discovered there, and that is what happened with the cytological lesion. Please remember, always dealing with low-grade lesions. High-grade lesions won't be treated here, because we know that we have to go in another direction when we're dealing with high-grade lesions. So only with low-grade lesions. Luckily for us, we didn't have glandular lesions, but because that would have been a problem. We used cytology and colposcopy to make sure that we had a low-grade lesion, and we know that this has been criticized, and we understand the reason why. Lots of people tend to think, they're right, that if we really want to prove that there's only a low-grade lesion, we should be performing a biopsy. We know that. And maybe we would change things now if we design the study. But at that stage, we didn't want to interfere in the normal response of that cervix. So we wanted to avoid the biopsy. So that's the reason why we use colposcopy. We use only low-grade lesion, cytologies, and colposcopy. And these are the results. When looking at the total population, we measured what was happening at 3 months and at 6 months with, please remember just what was happening with the lesion, with the cytology, and comparing the treatment groups with the control groups. The differences are pretty obvious there. If we then went to a special population, probably the most interesting population, in which we only considered the high-risk HPV population, the results were even better. So that in a way was a clear boost of energy for all of us, because we were not demonstrating, but we were seeing something that was very interesting. We're not only bringing the cervix back to normal, but we're also accelerating the process in which these patients will be eliminating the virus, especially when we're dealing with the high-risk viruses. This is the rate of clearance of HPV when measured at 6 months. We didn't measure it before that. It didn't make any sense. And these are the figures. When compared to a control group in which we had a clearance of up to 40%, the treated groups, A, B, different dosage, but we measured them together because if not, the number of patients recruited was too low. We had a 63% clearance. And that does make a difference. It does make a difference if we keep in mind what it means for this patient to know that she's an HPV positive patient. And it does make sense for us. This was published recently in the Lower Genital Tract Disease journal, and that clearly is good news for all of us. We've always made this effort. I mean, it doesn't make too much sense to just be presenting figures, numbers, and charts if we're not doing a huge effort to really publish all these data. So to us, that's an honor, and that's really good news. We know that we have to keep on pushing because we need bigger numbers to really have important data, but nevertheless, this is very interesting, this is important, and this has been considered as very interesting by the journal. What happened when we were dealing with Paloma trial? Well, something very interesting happened, that we already designed the Papillop study. Papillop study only was an observational study. We didn't have a control group there. So we only wanted to see what was happening in a normal practice. We were not comparing treatments. We were not comparing with a control group. It was just a way to look at what's going on in a normal practice. And these were the results. So that's why we say that real life efficacy, because we weren't comparing to any other group using the Coriolis versicolor based vaginal gel, and obviously again HPV positive patients and cervical low-grade lesions. And these are the results measured at first visit. This gray figure here is not control group. Please remember that it's just what happened at the first visit. Measured at 6 months and then measured again at 12 months. And these are the results. What was happening with the altered cytology abnormal smear? Then the figures are here, very, very obvious. At 6 and at 12 months, we were able to get that cervix looking right. And I know again that someone might think, well, but if you just show that there's a normal colposcopy and a normal cytology, you're not really telling me what's going to happen in the near future if you don't demonstrate that HPV has gone away. And you're right. But that's the way we designed the study at that point. But again, we also checked what was going on with the HPV, seeing if there was HPV there at 6 months or if there was HPV there 1 year later. And these are the numbers. So again, and this was pretty similar to what we saw with the Paloma trial, the figures are telling us that by using the gel, we were increasing the odds, the ratio, the capability of this patient to eliminate that viral infection. What happened then is that, and that was when we were still dealing with huge problems in terms of recruiting patients at the Paloma trial, some studies, independent studies, were published here in Spain. And there was also another study published in Italy, in Rome. And luckily for us, this meant that there was interest and something going on other than us. Clearly, by us working for the laboratory, things might have seemed a little bit weird, but since there was also some interest going around with other teams, that was great news, especially when they published their data and when they showed what they were dealing with and different designs of their studies. But if comparable, at least the figures they showed, the numbers, the results they had were the same as ours or even better. So that was really very, very good news for us. That was kind of a boost for all of us to keep on pushing with, despite the difficulties we were dealing with in terms of recruiting patients. So that was really very good news. You see, the overall HPV clearance went up to 63%, and that's really very good news. And that is with, and I know that maybe they shouldn't be strictly compared, but if we add all of the patients that we had there, it was over 700 patients. So that's really important. So, where do we think we can be using this vaginal gel? Well, clearly, please remember, we're not dealing with high-grade lesions. That's not the case. That's not our scenario. We're just dealing in the middle of this chart, meaning this. Either we have a normal cytology but with an HPV test, a positive test, or both things, low-grade lesion plus an HPV test. And that's where we think we should be using this vaginal gel. Again, I shouldn't be mentioning this, but we're not going to discuss about vaccination. We all have very clear what we have to do in terms of vaccination. So that's not the issue here, okay? So we do really think that we have a place in which we could be helping clinicians and obviously our patients by using vaginal gel in this group of patients, okay? Let's talk about those especially difficult cases. We do have two clear predictive factors that can be clearly related to viral persistence. And those are the genotype, which virus I've acquired, and age. This is a very classic publication. We've been using this as a reference for us. This is the Bogman's publication, in which they show us very clearly what the expected persistence of the HPV is at 6 months. If we're dealing with high risk, general high risk HPVs, and that is 71% persistence, 71% after 6 months, up to 59% at 18 months. And we will go and look at what happens if we just deal with HPV 16. The figures are horrible. 91% persistence at 6 months, 81 at 18 months. And that is in a study in which the average age was 38 years. So imagine now if we deal with patients that are older than that, in which we know, especially if they're menopausal, we know that their immune response probably will be a little bit less, okay? So let's keep on moving. There we go. This is the sub-analysis of patients older than 40 years in the Paloma trial, in the first one, because you know that there's an ongoing trial now, that's Paloma 2. When we just look at that special population, 40 years or older, these are the results by using, please remember, low-grade lesions, low-grade smears, low-grade cytologies, plus positive HPV test, plus more than 40 years. Average of age in this subgroup was 47, okay? And here are the results. Compared to control, 50% in the control group, 92% in the treatment group. So that again is a difference. I know that you can say that this number of patients is not big enough. Well, that's what we have. So that's what we can show you. Eventually, hopefully, we will have bigger numbers there. But the difference is pretty obvious there. If we look at what happened when we just looked at the special high-risk HPV population, and again, please remember the age, the figures were still there. We still keep that difference. Control against treatment groups. And remember here we had 2 branches of different treatments, okay? If we go and look at a now called very high risk HPV population, and that is 16, 18, and 31, the figures again are pretty significant. N is pretty small, so we cannot talk about the statistical differences there, but the tendency is as you see there. Let's move on to this next slide. This is HPV patients, HPV positive patients, obviously, 40 or older years, in both Paloma and Papillops studies. Obviously, when it comes to the chart in Papillops, there's no control group, okay? But these are the results of the Paloma trial, 90 against 33, when it comes to getting a normal smear at 6 months. What happened at Papillops, and remember Papillops didn't have a control group, and that might justify the difference. The percentage was 73.5%. Mean age, with both groups, with both studies together, 47.1. Remember that when we were looking just at the Paloma, we had a 47.7, okay? So it's still pretty high, closer to 50s. Okay, what can we do if we want to improve the clearance rates in these patients? Well, we need to in some way boost the immune response, and in some other way we should try and bring these vaginal microbiotas to CSTs type 1, 2, 3, or even 5. Okay, basically microbiotas in which the predominant germ there is lactobacillus. Okay, what do we know today about using polysaccharides, beta-glucans in terms of HPV clearance, and that is using oral treatments? Is there an immune boost effect by using all these substances? Well, the answer is yes. Again, numbers are still low, but there's a tendency there, and there's a tendency both in terms of normalization of low-grade cervical lesions and HPV clearance. That is using Coriolis or reishi, okay? If we go to this tiny, not tiny, but this small study here, again, supplementation with crispatus seems to be helping in terms of clearing HPV infections. So why not? There's a tiny note there that says with recurrent vaginal infections, and that clearly should be interpreted as if I don't have a stable vaginal microbiota and thus I have recurrent vaginal infections, then clearly I'm not helping my immune response in terms of eliminating this virus. So again, this basically saying, let's really go for it, and let's go for vaginal stable microbiotas with lactobacillus. Okay, and that's where we have a new strategy using immune booster substances, Coriolus, reishi, but on an orally prescription. And what we want to do is, are we going to be capable of demonstrating, and that eventually we should be able to do that with a new study that we should be starting probably within a few months. We're designing the study now, but it should be starting pretty soon. And we want to check what goes on, what happens if we use both vaginal and oral substances. This is the composition of this new product. Again, you've read about this hugely in recent papers. I mean, probiotics, the use of probiotics, reishi, Coriolus, is clearly something that's interesting, and we should be going in this direction. Okay, so can we recommend the management, or can I recommend, or can I tell you what I'm doing? Well, this is what I'm doing today. And I know that probably we should be waiting until we demonstrate that the use of oral products do help in terms of eliminating HPV infections. We should try to do that with the evidence. But nevertheless, we know that the market is flooded with tons of products, and our patients demand the use of pre and probiotics also orally. So this is what we're doing now. If I'm dealing with young women, HPV positive, without a lesion, it wouldn't make too much sense probably to use a vaginal product. So we would be using oral prescriptions. If that young woman again, is HPV positive and does have lesion, we've already demonstrated that by using the vaginal gel, we will help that patient. So we would be exclusively using the vaginal gel. What if our patient is 40 years or older? That's the patient that we earlier defined as especially complicated. So why not use everything we have? And that means oral strategy, but also local strategy with a vaginal gel. And if we want, we should be considering also the HPV persistent population, defining persistence for over a year, as also a very special and complex situation. And that's the reason why we would be recommending the use of both strategies, both oral and local treatment. So I guess this is all. So thank you very much.